Hey, hello everybody. I am Гаель. I'm a specialist in internal medicine, and I'm currently working in Sweden for Evidensia in a big private clinic, actually. And today I will be speaking about diabetes mellitus in cats. So we will start with a short introduction, and then I'll speak about the pathophysiology of diabetes in feline patients. We'll speak also about the clinical presentation of those patients. Finally, we'll see together how to make the diagnosis and how to manage them. So diabetes mellitus is actually a heterogeneous group of diseases with multiple etiologies, and it's characterized by hyperglycemia because of inadequate insulin secretion, inadequate insulin action, or both together. So that means that we can have insulin deficiency with beta cell loss, insulin resistance, but in most cases, especially in cats, we will actually have some degree of both diseases together. And it affects 0.4 to 1% of domestic cats. What's really important to remember, if you need to remember one cell in diabetes for cats and for dogs too, of course, it's actually the beta cells. And the beta cells, they are cells that are in the islets of Langerhans, in the pancreas, and they produce the insulin, and they really have a central role, a key role in the development of diabetes mellitus. So the health, the state of the beta cell is extremely important. So what happens if there is not or not enough insulin? It means that we will have a decrease in the tissue use of glucose, fatty acids, and amino acids. We will have an increase in the hepatic gluconeogenesis and glycogenolysis, which will lead to hyperglycemia, secondary glucosuria, and then some increase in circulating fatty acids and ketone bodies. So you need to kind of remember, if the cell is without insulin, the cell feels like it's starving. So in cats, often we actually speak of type 2 diabetes mellitus in analogy to the type 2 diabetes in people. And so many cats are overweight, and many overweight cats do not become diabetic. So it's also really important to remember it's not only insulin resistance. Again, the beta cell's health is central here. And so in the big majority of cats with diabetes, we'll have insulin resistance and beta cell dysfunction together. Also, the majority of cats actually do have a low to low normal concentration of insulin at the time of diagnosis, and they might recover from insulin secretory function when you reverse the glucotoxicity, so when you start treating them appropriately. Which cats are more at risk of diabetes mellitus? So every cat, of course, can develop diabetes mellitus, but it's a little bit more male cats that tend to develop that disease, also cats that are castrated, that are a little bit older, 11 years of age or more, cats that are inactive and or obese, often it goes a little bit together. And then the Burmese breed is actually overrepresented in studies with diabetes mellitus in European and Australian studies. In American population, not, but that might be because of a different genetic background. So I guess that you all know already a little bit the most classical clinical signs of diabetes mellitus. So what you expect to find in those patients are actually complaints of polyuria, polydipsia, polyphagia, but despite the polyphagia, some weight loss. Some patients can also be a little bit tired, a little bit lethargic, be a little bit weaker. And then a common complication in cats with diabetes is peripheral neuropathy with this typical plantigrade stance that you can notice on the hind legs. Of course, there are other possible diseases that can also give similar symptoms, and especially in an older cat, we think of hypothyroidism, which can also give polyuria, polydipsia, polyphagia, weight loss, and then polyuria, polydipsia in an older patient can, of course, be from chronic kidney disease. So I would say that's the two main differential diagnostics that you really need to consider when you face this kind of patients. On top of that, some cats, especially older cats, can have comorbidities. So you can have more than one pathology that's going on. And so that might also give a bit of other symptoms or contribute to some of the symptoms. Some cats will present with really systemic signs, anorexia, vomiting, dehydration, depression in a poor clinical state, and that might be because they already developed a complication of the diabetes, which is diabetic ketoacidosis, so DKA, And actually 34 to 50% of newly diagnosed diabetic cats do present immediately with DKA. So that's quite a big percentage. So now, once you have a suspicion, you will need to confirm a diagnosis. And so diagnosis of diabetes mellitus is clearly easier, more straightforward in dogs than in cats, mainly because of the existence of this stress hyperglycemia in cats, which can give hyperglycemia and even glucosuria. So there is actually, it might be straightforward and maybe you will show a few diagnoses, but there is also now some alive definitions that you can use and that we will discuss just after. Alive, it's actually agreeing language in veterinary endocrinology. So it is a group of specialists that are trying to really give definition for all endocrine diseases and concepts in veterinary medicine so that we all use the same terms for the same diseases and the same findings. Of course, you always need to be really sure that the diagnosis that you end up with actually do explain the symptoms of your pets and do explain all the symptoms. And you also need to make sure that you do appropriate testings, appropriate examination for the symptoms that were there in the first place. So in those patients, you will for sure need some, at least some blood and urine analysis. So let's go to the alive definitions that I was speaking about. So there are two cases of figure, actually. The first possibility that you have a patient with a random, so fasted or unfasted blood glucose concentration of 15 millimole per liter or more, with the classic clinical signs of hyperglycemia, with no other plausible cause, or already in hyperglycemic crisis, and then at least one of the following: an increase in glycated proteins. When we speak of glycated proteins, it means fructosamine and glycated blood protein, or glucosuria, but on more than one occasion on a naturally voided sample acquired in home environment at least 2 days after a stressful event. So that means that the owner will need ideally to collect that sample at home. You do not want to perform a cystosynthesis, which would be stressful for the cat. So it should be a little bit after the vet visit, as clearly a vet consultation is a stressful event for a cat. So what we usually do is that we let the owner order or buy those little special scent litter that's like non-absorbing actually. And so hopefully the cat will agree on urinating in the litter box with that. And then they can collect a urine sample with a little pipette and do a urinary dipstick at home to confirm or not the presence of glucosuria. Second case of figure, we do have a random fasted or unfasted blood glucose concentration that's between 7 millimole and 15 millimole per liter. And then you want at least two of the following criteria: the classic clinical signs of hyperglycemia without any other plausible cause or hyperglycemic crisis, an increase in glycated proteins, and again, glucosuria on more than one occasion on a sample that has been collected at home, far away from a stressful event. So what's really important when you do all those tests is to always use like species validated methods and to remember that conditions other than diabetes mellitus can actually affect the concentration, the level of glycated protein. And so it's important to exclude them. And so these conditions are mainly conditions that will give variation in the concentration of protein or the metabolism of those proteins. So here, especially in an older feline population, we really think of hypothyroidism. Hypothyroidism will give you a decrease of the fructosamine. And glycated blood proteins, they really need to be measured by methodology with relevant, internally established reference interval and regular quality assurance so that you can really rely on the results. So the workup will of course vary and it will be a little bit of a case-by-case approach, but at least you should have a biochemistry and a urine analysis performed in those patients. Ideally, you want a bit of a broader blood test with also a hematology, the electrolytes, a total T4 for hypothyroidism, and yeah, really the full urine analysis. And that's also because you don't only want to confirm diabetes mellitus, but you also want to rule out other differential diagnostics. If the animal is unwell and you do suspect that it's already in DKA, in diabetic ketoacidosis, then you will want to check a blood gas to look at the pH and see if it's indeed acidotic. And then case by case, you might want to check for pancreatitis with a feline pancreatic lipase, the IGF-1 for acromegaly, maybe perform some imaging, abdominal ultrasound. In some cases, why not X-rays of the thorax? So you will need to adapt a little bit to the patient and to the client, of course. So let's move on to the part of the treatment. So it's important to remember what you actually want to achieve with the treatment, and then to try to understand what you need to do to manage to meet those goals. So what you want is a good quality of life for both the pet and the owner, because it will influence the life of the pet, of course, but it's also quite heavy on the owner, because it will require daily monitoring and maybe daily medication. So you want, of course, to achieve resolution of the clinical signs. You do not want to have episodes of hypoglycemia, but you also do not want to have a diabetes that's insufficiently controlled and that the patient risks to go into DKA. And you want to normalize the body condition score of the pet. So if the pet is too heavy, you want to make him or her lose weight. And of course, if the cat is skinny, you want them to gain weight. So for that, what you need to do at the body, the cellular level, is actually decreasing the hepatic glucose output. You want to improve the insulin sensitivity. You want to make sure that there is an appropriate insulin availability. You also want to try to limit the postprandial hyperglycemia, and you want to diagnose and correct the underlying causes and comorbidities that you might have identified. So here I just put it a bit in other words. So the goal might be explained as wanting to maintain the glycemia below the renal threshold, so below the level of glycemia at which you will start having a lot of leakage of glucose in the urine, for as much of a 24-hour period as possible, while avoiding hypoglycemia. So renal threshold in cats for glucose, it's like 250 to 300 milligram per deciliter, 14 to 17 if you speak in millimole per liter. And hypoglycemia, it means that you have a blood glucose measurement that's less than 3.3 millimole per liter, which is the same as 60 milligram per deciliter. And that can happen with or without clinical signs. So here I put like the curve of one of my patients actually, and I was quite satisfied with that curve that day. The patient was doing well, which is of course the main priority for me. But then you can also see that the values, they actually kind of fluctuate between 16, 7.9, 7.8. So we are like still under the renal threshold most of the time. We're really far from a hypoglycemia. The patient is feeling well. So that's a good day. That's a good curve for me. So how are we going to manage? How are we going to treat the feline patient with diabetes mellitus? So there are, of course, different options, but I would say the most important to speak about and that you will need to consider in most likely almost all patients is actually insulin therapy and dietary modification. So for the diets, you actually have two main goals. You want to achieve the ideal body condition so that you can reduce the insulin resistance in overweight patients. But you also want to optimize the diet composition so that you can really optimize the glycemic control and increase the chances of going into remission. There are also some oral drugs that we can use for diabetic feline patients, and there is a little revolution nowadays in the management of feline diabetes with like new medication called SGLT2 inhibitors that are on the market and can be used instead of insulin. We'll speak about it a little bit later. And then you will really want also again to treat the comorbidities that you might have identified. So for the insulin therapy, it will be in injections, and then you can use all syringes or pens. And with some insulin, you will need, or the owner will need to give 2 times a day injection. And with some insulin, you can actually manage with once a day injection. There are insulin solutions and there are insulin suspensions. So the suspension, it means you need to mix it a little bit or roll it a little bit. It depends on the type, so that you can resuspend the product, which you do not need to do with a solution. So here you can already understand that maybe there is a little extra benefit in using solution, because solution will be like more the same every day when you inject it, while suspension, depending on how it was mixed, you can have a bit more variation, a bit more day-to-day variation, and you always want to try to be as stable, as regular as possible with diabetic patients. So they do exist veterinary insulins, and they also do exist human insulins. So here I put like the names of the ones that I use the most commonly in diabetic patients. So for veterinary insulin is the protamine zinc insulin U40 with a starting dose of 1 unit per cat 2 times a day. And for the human insulin, I tend to use the glargine U100, also same starting dose, 1 unit 2 times a day, or the glargine U300. And with this one, actually, you can try with once a day. So I usually start with 2 units per cat, but only once a day. But there are a lot of other options. So actually, you can really try to play with different types of insulin and really adapt your approach to the patient. If you're interested in that topic and you really want to go a little bit more into details with it, there is this really nice review called 100 Years of Insulin, Is It Time for Smart, written by Ren Giller, which is really nicely done. So on the next slide, it is actually a graph that's also coming from that review that I just mentioned. And I hope I can make it clear for you, but actually the endogenous insulin production does have 2 phases. You have the bolus one, which is the red line on the graph, and then you have the basal one, which is the green line on the graph. And so the bolus release of insulin is actually secreted in response to nutrients that are digested and absorbed from the intestine, and so it limits the postprandial hyperglycemia. So if we keep it a bit simple, it's you eat, there is a bolus release of insulin. And then for the basal insulin, it is actually secreted all the time, continuously, at a low, relatively constant rate. If we look at cats, they do not have the same glucose metabolism as us or as dogs. And so they actually have, like healthy cats at least, really a quite long bolus secretion. So the red line on the previous graph, that can be lasting from 6 to more than 12 hours, with a later and lower peak that can happen at 1 to 8 hours later. And in a study where they actually fed cats 4 meals a day, which is maybe more physiological for cats because they tend to like eating small portions, but more frequently also in nature, they had really only a minimal increase in insulin plasma, and this increase was sustained through 24 hours. So there was no clear bolus phase, and that might be a little bit more realistic, a bit more what really happens in cats. So what does that mean for the treatment of our patients? It means that if they still have some beta cells that are working, some residual beta cell function, which is the case in a lot of diabetic cats, giving only a basal insulin, such as the glargine 300, with only maybe 1 time a day injection, might normalize the blood glucose concentration. It might be enough, and if they are very small release of bolus insulin needed in between, the beta cells that are still working a little bit might be able to release the insulin needed for that. So for now, the effective safe basal insulin, or kind of basal insulin that we have on the market that has the same action every hour of the day, the closest option we have is actually indeed this insulin glargine U300 for cats. And to speak with one last slide about the insulin, actually there is a study about an ultra-long-acting recombinant insulin for the treatment of diabetes mellitus in cats that got published quite recently. And it is an insulin that's fused with feline immunoglobulin fragment crystal Isabel, and it actually gets recycled through the cells, and so it is protected from proteolysis, from destruction, which means that it has a very long, an ultra-long plasma half-life. And so in that study, they had cats that were well controlled on another type of insulin, on glargine actually, U100. And so they switched them to this new insulin. And what they saw is that after 7 weeks of once-weekly injections, there was no significant changes in clinical signs, neither in body weight, fructosamine, and mean interstitial glucose concentration, and there were no adverse reaction reported. So the conclusion is that they achieved a successful control of clinical signs and the maintenance of glycemia with this once-weekly novel insulin treatment. So imagine how much easier it would be for some owners and their cats if they could give, instead of maybe insulin once a day, 2 times a day, only once a week. That could make life much easier and could motivate people to treat and maybe make them a little bit less scared of having to inject their cat every day. So, no, the diet. The big question is the diet, is it really that important? And the answer is actually yes, in the big majority of cases, if you want to achieve remission. So if you do want and you think it's an achievable goal in that specific patient to achieve remission of the diabetes mellitus, then you will want to feed them a diabetic diet. When I speak about remission, I mean that there will be no evidence of diabetes mellitus after 4 weeks without any exogenous insulin treatment. And so in previously published studies, remission can be achieved in 15 to 100% of cases with a high protein, low carbohydrate diet and insulin therapy. So a diabetic diet, for example, like the diabetes management diet of Purina, it will actually provide proteins as main substrate for the cat, and it will have a decreased level of total sugars. So it will also be ideally suitable for a diabetic cat that will be prone to weight gain, because like we said, like being overweight will give insulin resistance, and so you want them to lose weight in a controlled fashion. It should also contain high quality ingredients and have a good palatability, because we know that cats can be really picky eaters, and you really do not want your diabetic patients to stop eating, which would make the administration of insulin more complicated and could potentially lead to complications such as hypoglycemia. So it needs to have all these like key factors to be a good, suitable diabetic diet. But there is a but, of course. What to do in some cases, like, for example, Silver. So Silver is one of my patients, which is a 19-year-old cat, domestic short hair, long hair more maybe, who is castrated, male, and he has developed diabetes mellitus in 2021 while he was treated with prednisolone corticosteroids for chronic pancreatitis, which was one of his big problems back then. And at that moment, we managed to discontinue the corticosteroids, we switched him to a diabetic diet, and we gave him insulin, and he went into remission. Then 1 year later, in 2022, he was diagnosed with chronic kidney disease. And so at that moment, in 2022, we had a cat that had this history of chronic pancreatitis. We also had a suspicion that he maybe had some chronic enteropathy, and he had like this chronic kidney disease stage 2, and he was hypertensive, non-proteinuric. So we managed him appropriately, and he received some renal diet and some antihypertensive medication. But then in August 2023, he was presented because he had more PUPD, he was drinking a lot again and urinating a lot again, and he had lost weight. So the owners were a little bit worried, and he came, we did a full evaluation and looked into all the possible causes for the symptoms. And that's actually a copy of what I wrote back then, and the list of all the problems I had with him. So he was clearly diabetic again, hyperglycemic and glucosuric and so on. So we had a relapse of diabetes mellitus. He still had this chronic kidney disease, IRIS stage 2, prehypertensive proteinuric that time. He had a mild hypercalcemia, which I thought was secondary to renal diet and phosphate restriction maybe. And then he had this history of chronic pancreatitis, maybe chronic enteropathy. We found some kystic changes on the liver on ultrasound, but they were more likely benign, so I was not worried about that. And then he also had hypothyroidism. He had a very high TT4. So what to do in that case with the diet? So of course we managed him. He received some vitamin B12, which was low. He received some amlodipine. He was started on methimazole for his hypothyroidism. He was restarted on insulin. So he had medication, but qua diet, actually, I switched him to renal function early care to try to see if it was resolving the hypercalcemia, which it actually did. But I didn't want to feed him a diabetic diet, because for the kidney disease, my only way to really try to slow down the evolution was to try to keep on feeding him a renal diet. So that was a choice I made at that moment. But there is another but. Sometimes, more or less every 10 months, Silver has a little flare-up of his pancreatitis and maybe enteropathy, and so he feels quite unwell for 2-3 days, and there's diarrhea and vomiting, and he needs supportive treatment at that moment. And at that moment, we also change his diet to a gastrointestinal diet to try to help him to recover and make it a little bit easier for his intestine. And he's really obsessed with the Purina EN, the gastrointestinal diet. So he's always quite happy to eat that diet for maybe a few weeks after he had one of the flare-up. And then we try to switch him back slowly to his kidney diet. So here you can see him, he was trying to open the closet of the consultation room to eat some food. So yeah, the conclusion of all those diet decisions is actually that you might need to prioritize comorbidities, especially in older patients, but that you still really do want a high quality diet, especially in an old cat with multiple diseases. You want to really make sure they eat enough and that they eat a good quality food that's really appropriate for them. You also really want to avoid sudden change in diets. Again, cats are picky eater and they could really stop eating if you change too fast. And you can also actually have gastrointestinal symptoms due to a too fast change in diet. So important to make slow transition. And then one last key aspect of the diet is that you need to optimize the body condition score of those diabetic patients, which means for some patients weight loss, but sometimes also weight gain. So there is another really nice review about that topic called Pathophysiology and Management of the Obese Diabetic Cat. And I took a few key information from that review for you that I also apply to my practice. So up to 40% of the feline population is overweight, obese. So it is a lot. And obesity leads to insulin resistance through multiple pathways mechanisms. Each excess of kilogram body weight actually gives a 30% decline in insulin sensitivity. So what does that mean really practically? It means that obese insulin-resistant cats with concurrent beta cell dysfunction are at risk of progression to overt diabetes mellitus, and obese cats are 2 to 4 times more likely to develop diabetes than cats of an ideal body condition score. So to feed the obese diabetic cat, there are a few steps that can make your life a little bit easier. If there is active weight loss that has occurred at the moment of diagnosis, you first want to stabilize the situation. So you want to treat the cat with insulin before you start caloric restriction. And you will at that moment also try to ask the owners to measure the caloric intake. Once the body weight is stable or increasing, if you need to have further weight loss in that patient, you will need to calculate the caloric requirement for the ideal body condition score, for the ideal body weight. So that's the formula that is here written down. Don't forget, body weight, it's the ideal body weight, not the current body weight in kilos. So then you will need to select a diet. And ideally, you would like to feed them a canned food, actually a wet diet with less than 12 to 15% of metabolizable energy as carbohydrate and more than 40% as protein. If this is not tolerated because the cat does not like it or because it's too much restriction of food intake, then you might want to consider a high protein, low fat, moderate fiber, moderate carbohydrate diet. So you might need to compromise a little bit, like we often do with cats. If the cat body condition score is more than 7 out of 9, then maybe it makes more sense to first start with a diet that's really designed specifically for weight loss. And if there are concurrent diseases, like we said, comorbidities, like in Silver's case, you might need to change diet and to choose another diet. For the food, you will feed 80% of the resting energy requirement or 20% less of the caloric consumption of the cats that you have assessed in the beginning of the process. And then you really want the owners to check regularly the body weight. You do not want the patients to lose too much weight too fast. So the cat should be on a scale every 2 to 4 weeks. And then the amount fed should be adjusted so that you have a weight loss of 0.5 to 1% body weight per week. And so last part of treatment discussion for today, because it's, like I said, a little revolution in the management of feline diabetes, so I do need to mention it. There is a new class of medication, of drugs, called sodium glucose cotransporter 2 inhibitors that is now available for cats for treatment. And yeah, there is one option on the American market and one on the European market. And so these SGLT2 inhibitors, they work by inhibiting a little protein, a little membrane protein that's located at the first part of the proximal tubule of the, I went too fast, of the kidneys. And so here this image comes from a YouTube video. You can watch it fully if you wish. It was really well done and quite short. It's like for human, because we also use this medication in human, but in people, but it's exactly the same mechanism for cats. So as you can see, normally the little SGLT2 pump is actually responsible for the recovery of more than 90% of the glucose that is filtered and that ends up in the glomerular filtrate. And so the drug actually really stops that. So you will have less reabsorption of glucose, so more glucose that will be excreted in the urine. And so it will lower the plasma glucose and so normalize the symptoms and reverse the glucotoxicity. And so in Europe, it's the velagliflozin that exists now for cats. It's a liquid solution. In the States, it's bexagliflozin. So they are both from the same family. They are both these SGLT2 inhibitors, just a little bit of a different molecule. What's really nice is that's a once daily oral medication. So there is no need for injection. Of course, it is still a little bit less physiological than giving insulin, but for cats or for clients, for people for who it is really impossible to give injections, that is a very nice alternative. It is still a new treatment, so we don't have so much data yet. And what I just wanted to mention is that there is a risk of euglycemic diabetic ketoacidosis. So as they will urinate the excess of glucose, they might go into DKA, but if you measure the blood glucose, it will still be normoglycemic. So that's important to know for the patients that are treated with that drug, that you should not rule out DKA based on normoglycemia. And then it can give some possible gastrointestinal side effects. It seems like it's diarrhea, the most common adverse effect. So with that, I'm actually reaching the end of the presentation, even if we could speak for days about diabetes mellitus, but I hope that you learned a few things from that presentation. And if I would have like a take-home message, I would say that you need to remember that cats, they have diabetes mellitus because of both insulin resistance and beta cell dysfunction, that obese cats are 2 to 4 times more likely to become diabetic. So it is a lot. If you have a doubt about the diagnosis, you're not so sure, you doubt about stress hyperglycemia and so on, you can always follow this ALIVE criteria for diagnosis to help you. That it is really important to feed these animals a high quality diet, but it does not mean that it will only be and always be diabetic diet. You might need to adapt and choose another diet due to comorbidity. Then there are different types of insulin. So it's not only one type 2 times a day. You can play a little bit around and you might be able to use a once a day injection if you choose, for example, the Glargine U300. In the future, we might even be able to give a once a week injection. So it's even better. And then there are these new therapeutic options, which might be really nice in a lot of uncomplicated diabetes mellitus cats that cannot be injected with insulin, and that will be a oral once a day SGLT2 inhibitor. So thank you very much for your attention. If you have questions, you can always try to send me a little email. I put my email address there. I, of course, want to thank Purina and Evidensia today for the support of the presentation. And at the end, I have my bibliography if you're interested in reading some of the articles that I mentioned in my presentation. Bye-bye.